Why do you want to know about the future of Medicare? What I plan to do today, the goal is to give you the facts and information that you need to go back home and educate your colleagues and your patients. Now, I acknowledge the fact that many of your patients may not want to know the facts about Medicare or the future of Medicare because they are operating under the assumption that they've been paying into the Medicare program over the years of their working life, and it is their belief that that money was put in some account someplace, earning interest and growing, so it would be there to pay for their care when they retired. And that, of course, is not the case. And also, there are some of your colleagues who don't want to hear this information because they are busy pressing that bar, hoping to get another pellet of food come out of the chute. And of course, over the years, and as the years continue, they will be pressing that bar more times to get a smaller and smaller food pellet. But that's what they know because they grew up in the cage. So with that being said, let's go on our journey here. In order to understand the future of Medicare, you really have to understand several things. Number one, you have to understand the Medicare basics, the ABCDs of Medicare. You have to understand how Medicare is financed, and you need to know something about the demographics of Medicare. I will then cover some of the information that's been provided in the 2014 annual report of the Medicare Board of Trustees. So let's start with some of the Medicare basics. There are 4 parts to Medicare. Medicare Part A, also known as hospital insurance, and you'll see that abbreviated HI. Medicare Part B, which you're familiar with, is the part that pays physician fees, also known as Supplementary Medical Insurance, abbreviated SMI. And Medicare Part C, called Medicare Advantage, although there's little advantage to it since it largely consists of HMOs which ration care. And Medicare Part D, which is drug coverage. And we'll mainly be talking about Medicare Part A and Part B today. You also should note that Medicare is part of the Social Security Act amendments, Title 18, which was signed into law July 30th, 1965. And I would imagine that many of you have the AAPS card. If you don't have one, you can get one out at the front desk there. But if you look on the back of the AAPS card, you'll find some of the promises that were made and codified into law so as to get physicians, primarily the AMA, to go along with Medicare. And you will also note that the government has broken basically all of these provisions. In Section 1801, the government said they weren't going to interfere with the way medical care was provided. They weren't going to set fees. Well, they broke that a long time ago. And of course, Section 1803, they said, well, you can go out and buy whatever private insurance that you want. We're not going to do anything to prohibit that. Yet the government destroyed the private insurance market for those 65 and older. So even though you may want to go out and buy private insurance as an alternative to Medicare, you cannot do it. Now, although the hospital insurance and the supplementary medical insurance have the term insurance in their name, they are really not insurance. They're not insurance because there's no binding contract and there is no catastrophic coverage. And that's going to come as a shock to some of your Medicare patients who think that, you know, they're covered for all costs, that includes catastrophic coverage. And again, as I pointed out, there is no private insurance alternative to Medicare for those 65 and older. So what's the situation? Well, taxpayers have no binding contract with the U.S. government for future Medicare benefits. And this is something that Sue Blevins covered in her book entitled Medicare's Midlife Crisis. And quoting from that, the program was enacted as part of the Social Security Act amendments of 1965. And the U.S. Supreme Court has ruled that Social Security is not a contributory insurance system because Social Security taxes are paid into the general treasury. The trust fund is merely an accounting mechanism. And of course, the 2 cases that basically showed, the Supreme Court cases, that there is no binding contract and you have no the government has no obligation to provide you with benefits is Helvering v. Davis in 1937 and Fleming v. Nestor in 1960. So what about this fact that Medicare does not provide catastrophic coverage? Well, unlike true insurance, Medicare does not provide catastrophic coverage, and out-of-pocket costs are not limited. In fact, Medicare works exactly the opposite of true insurance, the way true insurance should work, to protect beneficiaries from financial loss from severe catastrophic illness. Remember that the purpose of insurance is not to provide health care. That's what the insurance company and the government may want you to believe. But the purpose is to protect your finances from catastrophic losses due to an unexpected catastrophic illness. However, when a Medicare beneficiary suffers a catastrophic illness, the Medicare program pays less, not more. So, for example, after 150 days of hospitalization during any benefit period, which certainly could occur with a catastrophic illness, the Medicare beneficiary is responsible for 100% of daily hospital costs. And that is why, the government says, well, they recommend you should go out and buy a Medigap policy to make sure that you don't incur catastrophic bills. But the truth of the matter is, Medigap policies do pay for copays and deductibles for hospital days beyond the limited 150 days, but they do not provide catastrophic coverage. And again, this information is from the booklet that they pass out to beneficiaries, Medicare and You, which is provided by the Centers for Medicare and Medicaid Services. So how is Medicare financed? And to answer that question, you have to know that Medicare Part A and Medicare Part B are financed very differently. Medicare Part A, the hospital insurance, is primarily financed by payroll taxes, 88%, whereas premiums only account for 1.4% of the revenue in Medicare Part A. Medicare Part B, on the other hand, SMI, is largely funded through general tax revenue, 73%, and premiums account for 25%. So the Medicare beneficiaries, although they may believe that they're paying the cost of their care through these premiums, really aren't. They're being paid by payroll taxes and general tax revenues. And this next slide just kind of shows this is from the Medicare Trustees report, the current one, showing what the actual figures were for Medicare Part A and Medicare Part B. So, of course, the payroll tax, which is the primary funding source for Medicare Part A, is paid partly by the employer and partly by the employee. Each pay 1.45%. And if you're self-employed, as many in this room are, you know that you pay the self-employed tax of 2.9% of net earnings. And due to Obamacare, it started in 2013, high-income workers pay an additional 0.9% tax on earnings above an index threshold, which is about $200,000 for a single person and $250,000 for a couple. So what's the history of what's happened to the payroll taxes over the years? Well, Medicare was passed in 1965, went into effect in 1966, and at that time the payroll tax used to support Medicare was 0.7%. And in 1965, the forerunner of the Department of Health and Human Services, which was known as the Department of Health, Education, and Welfare, the secretary told the Senate Finance Committee that by 1987, payroll taxes would not exceed 0.8%. And they never get it right. Every time the government predicts what the cost of one of these government programs is going to be, they get it wrong. And in this case, the actual was more than 4 times that predicted. Now, some of you may not know, but Medicare Part B has been means tested since 2007. Remember when Medicare was passed, it was to provide the same benefits at the same cost for all beneficiaries. But in 2007, it was from each according to his abilities and to each according to his needs, and it became means tested. So the standard premium currently in 2014 is $104.90 per month. And those who earn a modified adjusted gross income over a certain threshold pay a premium surcharge ranging anywhere between $146.90 to $335.70 per month, again indexed per the income. So the premium surcharge threshold this year through 2019 is $85,000 for individuals and $170,000 for those filing joint tax returns. So they're really now applying this to people who are not making excessively high incomes, and those who are making higher incomes are now paying more for both Medicare Part A and Medicare Part B. So the number of beneficiaries that were subject to this means-tested premium was 2.4 million, or about 5% of enrollees in 2011, and it is expected to increase to 7.8 million, or 14% of enrollees by 2019. Medicare Part D, by the way, is also means-tested. So let's talk a little bit about the so-called Medicare trust funds. There are actually two Medicare trust funds. There's one for HI, the hospital insurance, Medicare Part A, and one for SMI, Supplementary Medical Insurance, Medicare Part B. So the way it works is that payroll taxes, beneficiary premiums, and general revenue go into the respective trust funds, and annual expenditures for Medicare are paid out of these trust funds. It is a pay-as-you-go type system. It is Ponzi-like. It is not entirely a Ponzi scheme, because at least in a Ponzi scheme, people had a choice whether or not to invest their money, and they did so. People invested their money in Ponzi schemes based on greed. They were looking to double their money within a few weeks, and it was a great deal. But unlike a Ponzi scheme, this Ponzi-like scheme, people are forced to participate. So every year, the Board of Trustees for HI and SMI are required to report to Congress on the financial stability and actuarial status of these trust funds. So here's what they say, and this is the Medicare Board of Trustees. The Medicare Part A is headed for insolvency. We all know that. We've known that for some time. If you look at these Board of Trustees reports that have been coming out, that's been saying this for years. Medicare Part B, however, is not at risk for insolvency. And again, it goes back to the way that these two different funds are financed. The Medicare Part B is reset every year based on expenditures from the previous year, and they adjust the general tax revenue and sometimes the premiums to account for that. So you can always raise taxes more, and that's why the Medicare Part B will not ever become insolvent. So what essentially are the Medicare trust funds? Well, what happens, for example, if the government takes in more revenue than they expended in a particular year? Those excess funds are actually invested in special, non-marketable U.S. Treasury bonds at a market rate of interest, and of course the interest is paid by taxpayers. And these special U.S. Treasury bonds are backed only by the government's promise to repay. They are essentially IOUs. And repayment of these special bonds depends on the younger generation's ability to pay increased taxes in order to repay the IOUs. So there are no actual assets or money in these trust funds, only the government's promise to repay. So the trust funds, the Medicare trust funds, essentially are an accounting gimmick. The trust fund is considered an asset to Medicare and simultaneously an equal liability to the U.S. Treasury to be paid by taxpayers or additional borrowing or printing money. The Medicare trust funds then represent claims on the U.S. Treasury. And of course, to make matters worse, Congress saw this little pile of money accumulating there and decided to raid the Medicare trust funds to pay for other government programs. So that's made it even worse. In times of excess revenue over expenditures, it was not left in the trust funds. It was taken out and spent by Congress on other programs. So what about the demographics of Medicare? Well, when Medicare was passed back in 1965, there were about 4.5 workers for every retired person. And as you can see, what's happened over the years, that ratio, the number of workers paying taxes to support Medicare beneficiaries, has steadily declined. In 2020, the ratio will be 2.8 workers per Medicare beneficiary, and in 2030, it will be 2.3 workers per Medicare beneficiary. So you can see, based on the demographics, what's going to happen to the taxes and that sort of thing, what's going to happen to Medicare benefits will be reduced, taxes will be increased, likely more borrowing and likely more printing of money. Another way to look at this is something called the dependency ratio. That is, those outside the working age, under 18, over 64, per 100 working age adults, age 18 to 64. So the higher the dependency ratio, the fewer working people are supporting non-working age people. And in 2010, the dependency ratio was about 59. By 2020, the Census Bureau estimates it will be 65, and by 2030, the Census Bureau estimates that that ratio will be 75. So you can see this graphically. That's what's happening is that those Americans age 65 and older are a growing segment of the population. And largely right now, if you look at that steep part of the curve, a lot of that's due to the baby boomers retiring. And this is a graph of the projected U.S. population growth, showing that not only are those age 65 and older a growing segment of the population, but the very elderly, those age 85 and up, are an especially increasing proportion of the population. So the baby boomers, that is those who were born between 1946 and 1964, immediately starting after World War II, about 75 million baby boomers is the total population of baby boomers, and every month about 250,000 more baby boomers turn 65. And by 2030, those over the age of 65 will account for about 20% of the entire population. So just to compare the numbers a bit, currently there are about 52.3 million Medicare beneficiaries age 65 and above, and about 8.8 million disabled individuals on Medicare. So the number of baby boomers coming into the Medicare program will more than double the number of beneficiaries on Medicare between 2011 and 2029, again, based on a retirement age of 65. We know that not everyone's going to retire at age 65. And if you look, the total Medicare expenditures in 2013, the latest year for which we have numbers, total expenditures exceeded total revenue by $7.1 billion. So you can see the problem. Right now, we're at the beginning of the retirement age for baby boomers. And right now, we're already running a deficit of $7.1 billion. And by the way, the HI, the Medicare Part A expenditures, have exceeded income annually every year since 2008, and they are projected to continue to exceed the revenue. So here's the 2014 Medicare Board of Trustees report. You can get this online and read the entire thing if you're having trouble sleeping. And again, the Social Security Act established separate boards for HI and SMI, but since the boards have the same membership, they are simply referred to as the Medicare Board of Trustees. And the Medicare Board of Trustees consists of 6 people. 4 members serve by virtue of their position in government: Secretary of Treasury, Secretary of HHS, Secretary of Labor, and the Commissioner of Social Security. 2 are public trustees who are appointed by the President and confirmed by the Senate. And the CMS, the Centers for Medicare and Medicaid Services Secretary, serves as Secretary to the Board of Trustees. So here are the Board of Trustees. And I don't know if you can read that back there, but if you look in the lower right-hand corner, there's a public trustee by the name of Robert D. Reischauer. Does anybody recognize that name? Yeah, we recognize that name. And he's an economist who's been a very strong advocate for single-payer health care, and he's prominently featured on the Physicians for a National Health Plan website. And again, I'm quoting from the Congressional Record. Robert Reischauer, CBO, Congressional Budget Office Director, testifying before a hearing of the House Ways and Means Committee's Health Subcommittee, asserted that government-imposed limits on medical expenditures could substantially reduce the rate of increase in health spending. So they like government price-fixed fees by central planners, who are very smart, by the way. But he added that the likelihood of success increases with a single payment mechanism, restrictions on the ability to purchase health care outside the regulated system, and government-set budgets for hospitals and other institutions. So they like systems where there's no escape. It's more efficient. They can run things better if there's no escape. Everybody in, nobody out. Now, when you look at this very thick Medicare Board of Trustees report, of course it's centered around their projections about what's going to happen. And you'll note that one of the things they say a number of times in the report is that the projections are really very uncertain. Medicare's actual future costs are highly uncertain for reasons apart from the inherent difficulty in projecting healthcare cost growth over time. That's from the 2014 Board of Trustees report. So they're basically admitting these are really rough guesses that are highly uncertain. So here are their projections. And if you look at current law, which is the bottom line here, the bottom dashed line, current law, the assumptions that they make are that the sustainable growth rate reduction in physician payments occur, and other Obamacare mandated reduction in other Medicare payment rates occurs. So this is a very rosy scenario where they cut Medicare physician fees by 25%, and all of the cost reduction features of Obamacare occur. Then there's the projected baseline, the line in the middle, the solid line, where the assumption is that the SGR payment reductions will be overridden by Congress, as they have every year since 2002. And then there's the illustrated alternative, the top line, which assumes an override of not only the SGR cuts, but a partial phase-out of the Obamacare reductions in Medicare payment rates between 2020 and 2034, plus a legislative override of the cost-saving actions of the Independent Payment Advisory Board. So now they're starting to fudge a little bit. They realize that cutting physician fees 24 to 25%, probably that's not going to occur. There'd be a huge access problem. And they're also applying that same thought process to the IPAB, which was supposed to be the rationing mechanism under Obamacare to basically reduce costs. And this is Medicare expenditures as a percentage of the gross domestic product. And one thing I would like to point out to you is the part highlighted in yellow. If you look at the Medicare expenditures in this area here, you will see that they actually started to decrease before 2010 when Obamacare was passed into law. So that's an important point, and I'll go back to that a little later. So the board predicts, this is very interesting, the Medicare Board of Trustees predict that access to care and quality of care for Medicare beneficiaries will suffer if transition to a so-called more efficient model of care delivery does not occur. So here's the quote from the report. However, if the health sector cannot transition to more efficient models of care delivery and achieve productivity increases commensurate with economy-wide productivity, and if the provider reimbursement rates paid by commercial insurers continue to follow the same negotiated process used to date, then the availability and quality of health care received by Medicare beneficiaries would, under current law, fall over time relative to that received by those with private insurance. So they know what's going to happen if their view of utopia doesn't occur. And here's the graph which illustrates their predictions. The line highlighted in pink there, HI, which is Medicare Part A, it becomes insolvent in 2030. So that is their current prediction. As you can see, the other things there are in significant trouble. The disability part of Medicare And the OASI is actually Social Security. So you can see that all of those are in a downward trend and will hit the baseline at some point. So this was their major conclusion from that, is the estimated depletion date for the HI trust fund is 2030, 4 years later than was shown in last year's report. Now, is that cause for great celebration? Well, apparently many in the media thought so, because we saw stories like this. Outlook for Medicare is improving, the report says, and you know what? It's partly due to Obamacare. Yeah. Now, my PhD is not in economics, and the central planners are clearly smarter than the rest of us, at least that's what they tell us. But I kind of look at things in a simpler way, a more down-to-earth way. So here's the graph that I've come up with to sort of explain the situation. A man climbs 2,500-foot Mount Medicare and jumps off the top, and we can kind of predict his trajectory that he's probably going to land here. But instead of landing there, he lands 4 foot in front of that. And is that cause for celebration? Should we call this man's wife and say, I have bad news and I have good news? The bad news is, your husband climbed up to the top of the mountain, jumped off, fell to the ground, and died. But the good news is, he landed 4 feet in front of where we thought he was going to land. So again, actually, you know, Obamacare, they're trying to link that. That must be due to Obamacare. But again, if you look from the Board of Trustees' own report, the spending slowed down before 2010, which was when Obamacare was passed into law. So, you know, the media is fawning, some of the media are fawning all over this. But what does the Medicare Board of Trustees report actually say about the impact of Obamacare? And here it is. In recent years, U.S. national health expenditures growth has slowed relative to previous historical patterns. There is some debate regarding the extent to which this cost deceleration reflects one-time effects of the recent economic downturn, the recession, versus the extent to which it reflects positive reforms in the healthcare sector that may carry forward to produce additional cost savings in the years ahead. And the trustees are hopeful that U.S. healthcare practices are in the process of becoming more efficient as providers anticipate a future in which the rapid cost growth rates of previous decades, caused by government, in both the public and private sectors do not return. But they admit the Patient Protection and Affordable Care Act, as amended by the Health Care and Education Reconciliation Act of 2010, introduced large policy changes and additional projection uncertainty. So although the media are fawning over this and saying, wow, look, it's Obamacare, this is causing Medicare expenditures to go down, it's wonderful. The Board of Trustees admit there was a little thing in there called the recession that could be responsible for a lot of that. And this is a graph from the Commonwealth Fund, and as you can see, they looked at national health expenditures both before and after Obamacare, and basically they continue to rise and are predicted to rise at an even faster rate. And of course, one thing we know for sure is that the percent increases in health insurance premiums are just going sky high. That's the blue and the red lines here. And if you look, the blue line is starting to separate a bit from the red line, meaning that workers are expected to pay more of the cost of their health care premiums. So that we know for sure. The Medicare Board of Trustees report also says the HI Trust Fund has not met the trustees' formal test of short-range financial adequacy since 2003. So it hasn't even met their own formal test of what ought to be adequate for this system since 2003. The report also says the trustees project that the HI tax income and other dedicated revenues will fall short of HI expenditures in most future years. So they admit we're well into deficit spending, and it's expected to continue. The HI trust fund does not meet either the trustees' test of short-range financial adequacy or their test of long-range close actuarial balance. So it doesn't even meet their own formal tests for short-range and long-range viability. So what is the future for physicians who remain in the Medicare program? Well, as Bob showed you yesterday, here is a graph of the Medicare physician fee updates, the green line at the bottom. And again, the Medicare physician fee updates have remained pretty much flatline over many years now, with the exception of 2002, when, if you recall, the SGR cut of 4.8% went into effect. But in all other years, it's been 0 or 0.5 or something in that range. But the red line there shows the practice costs, which continue to diverge greatly from the Medicare physician fee updates. And this is from an article by Scott Gottlieb. And the Obama administration's assumption all along has been that doctors earn too much. For Obamacare to succeed, American doctors need to earn less money. And clearly that is the view of the Obamacare administration. And you can see this in the Medicare Board of Trustees report, which hopes that early introduction of these reforms will give physicians more time to get accustomed to earning much less, and will give patients and taxpayers more time to adjust their expectations. You know, they phrase this in ways, it sounds, you can't figure out what they're saying. Here's the quote: early introductions of reforms increases the time available for affected individuals and organizations, including healthcare providers, beneficiaries, and taxpayers, to adjust their expectations and behavior. I mean, they could have just as well have said, look, this is the frog in the frying pan. If we turn the heat up gradually, it gives them time to kind of get accustomed to what's really going to happen to them. So here's what's going to happen to the physicians who are still in the Medicare program. The scheduled fee update for 2015 is 0, snake eyes. And between 2016 and 2023, it is going to be 0.6%. So what are some of the conclusions? Well, Medicare Part A is clearly headed for insolvency. We've known that for some time. They continue to report this in the Board of Trustees report every single year. And the biggest thing on the horizon is the demographics, the so-called demographic time bomb, the large number of baby boomers who are coming into the system. We can't pay for the system as it is, and the number of people on Medicare is going to double. And the Medicare program as we know it today is simply not sustainable, and that's basically admitted in the annual report of the Board of Trustees. The so-called trust funds, that they make people believe that these are actual money assets available to pay for your care. They're really worthless IOUs. And again, Medicare is financed like a Ponzi type scheme. And we know one thing about all Ponzi schemes: they ultimately collapse when they run out of other people's money. So it's not a question of if they're going to collapse. A Ponzi scheme always collapses, and it always hurts a lot of people when it collapses. So the Medicare beneficiaries, physicians and taxpayers, particularly younger age taxpayers, will suffer greatly as Medicare begins to collapse, because they will try and save the system by increasing taxes dramatically on the younger working age group. And physicians do have the option of opting out of Medicare versus going down with the ship, a choice which gives patients more freedom and more choices. So as this goes along and we continue to pursue that line toward the ground, the care for Medicare patients, the quality of care and access to care is going to suffer. So this is something that's going to hurt our patients, and they should know about it. And I believe we have an obligation to educate our colleagues and patients about the facts of how Medicare is financed and what the future holds for them. Thank you very much for your attention. take a couple of questions?
Yes.
I guess we can take a couple of questions.
Yeah, we have time for questions. I know everybody would ask.
Now remember, my PhD is not in economics, and I'm not as smart as the central planners who are so smart they can determine the price for everything you do, and they can make all of those decisions about supply and demand that millions of people make on an individual basis, on a daily basis. So take questions, comments.
Don't ever let this guy do comedy. My God, you're depressing. It occurred to me while you were talking that here's an opportunity for the AAPS, and I'll make it happen. When I talk about being activists and being active in what you do, here's what I want you to do. So now I'm going to give you homework because you've just made me want to go back to bed. I'm glad my mother's not in a position where she'll need this. And fortunately, I earn enough where if something catastrophic happens to her, I can at least help her. Take this. I need 2 versions on the AAPS website. The version that's what I call the 10 to 12 page version that people can digest quickly. The full version, and I need you to put this into a 15 to 20 minute presentation for my show. Over the course of an hour, and if it gets interesting, maybe 2 hours as people get depressed as I did, you come on the show, you explain this, you drive people to the AAPS website, because rather than trying to convince them, you show them and you demonstrate and you tell them where they can go. They'll choose which version they want. What'll you do? You'll explain the problem, you'll show them the sourcing, and you'll drive them back to your website. And now people will know there's an organization, or more people will know there's an organization that actually has real information they need. Fair enough?
Fair enough.
All right.
And
you have 1 week.
And actually, it's not usually a matter of me telling them where to go. Usually they do that to me. And remember that a lot of people, the government's made them dependent on Medicare, and they're afraid. They don't. This is frightening to hear.
But see, what I'm talking about is not only giving them the information, but driving them to the organization. Taking every city in this country, every trucker, every home, every business where I can reach into, and doing this, and then finding other hosts locally and repeating that. This is what activism really is. It's presenting information that they can't avoid if they choose to go to it. So, 1 week.
Thank you, very generous.
Larry, great talk. An article just out a day or 2 ago in Modern Healthcare says healthcare spending already up in 2014, back up to 5.6% rate of inflation versus 3.6% back in 2013. So it's already kicking up. Could you just comment on the mandatory nature of Part A versus the optional nature of Part B, and what seniors can perhaps do in terms of their choices?
That's a very good question. And a lot of Medicare beneficiaries don't know this. But if you fail to sign up with Medicare Part A when you turn 65, you lose all of your Social Security benefits. You will not receive checks from Social Security if you refuse to sign up for Medicare Part A. So it's voluntary. Yes, you can refuse to sign up, but everything that you paid into Social Security with the expectation of getting something out is gone. Medicare Part B, on the other hand, yes, you can also not sign up for Medicare Part B. You can sign up for Part A, but not Part B. But the government also applies a penalty to that as well. So if you don't sign up for Medicare Part B, which is the physician fee component, what Medicare does is if you want to get into Medicare Part B later, the time that you are out of it, past the age of 65, they increase your Medicare monthly premium drastically. So those are the choices. But I think most patients don't know that this is not optional, the Medicare Part A, really, because a lot of people do depend on the supplement to their income of Social Security, and the government makes sure you don't get that if you refuse to sign up for their program. So it's a program with no escape. That's the way it was designed.
As another choice, as an example, Atlas MD charges $100 a month for people over 65. If I had access to something like that, there's no way I would sign up for Medicare Part B, and I'm only a year and a half away from looking at this. I don't know of anything like that available in my area where I live. If I sign up for Medicare Part B and then another alternative becomes available, is Medicare Part B a one-way street, or can I then opt out of Medicare Part B
It's my
after I've
understanding
signed up?
You can stop paying premiums and get out of Medicare Part B, but I believe that there's also a penalty that will apply if you decide to get back into it again. And again, the time period that you're out of it, they will penalize you drastically.
Same is true for Part D.
Part D as well.
All right, thank you very much. I've been studying a phenomenon that I call stealth euthanasia developing in this country. And as I looked at some of the literature, it said that one of the savings in Medicare is the lower cost of nursing homes and skilled care nursing, because otherwise that's the part that Medicare pays. And yet it seems that there are many, many more patients that are turning 65 or getting older and are in need of this. So this seems to be a little discrepancy. At the same time, there's this tremendous increase in hospice referrals. And we all know many of which are inappropriate, and it's done without the physician's judgment that that is an appropriate thing. And the hospice industry, which is paid directly by Medicare, has grown tremendously. One of the third, I think it's like the third most profitable healthcare portion. So if you put that together and your clinical experience that often when people are referred to hospice, appropriate care is denied because that's a kind of a big HMO where anything they spend has to come out of what they make. So the less they spend, the more they keep. So you can draw your conclusions from that. And if that is not recognized and rectified, you're gonna see tremendous savings. And it seems to me government isn't going to need to do rationing. It's de facto rationing at that point.
Good point. You might also remember several years ago, in hospice care, the doctor has to certify that that patient's likely to die within 6 months. That's the eligibility criteria for hospice care. And you may recall, a number of years ago, the government was requesting money back because the patient didn't die within 6 months and lived longer, and they wanted their money back that they were paying to these hospice programs. And they were even looking at some of the doctors, in a fashion where maybe the doctor committed fraud because he certified this patient was going to be gone in 6 months, and here this person is living. They have the audacity to live another 6, 18, 24 months.
Larry, I'd like for you to strongly consider changing your use of terminology. You refer to Part A as hospital insurance. And I think this is leaving totally the wrong impression. Part A is a pure and simple benefits program.
Now, that's their term, not mine.
I understand, but in terms of discussing it and explaining it to people, especially distinguishing between Part A and Part B, where Part B is an insurance program where the individual pays a premium, in Part A they do not.
Neither one's an insurance program. Neither one. To be an insurance program, you have to have a binding contract. If you've got private insurance, you have a binding contract with your insurer. You agree to pay the premiums, and the insurance company agrees to cover the specified benefits. But these, neither one, Part A or Part B, are insurance.
Okay, well, I don't think the people who hear you talk understand that distinction. They believe Part A is an insurance program. So again, perhaps change your words so that they would understand it is not an insurance program.
Carol Highland from the Mobile area in Alabama. Larry, can you address what mixture of Medicare benefits versus cash for the patient is legal? How can cash-based physician practices, how can they work with patients, that are forced to be on Medicare?
Right. Well, the first question is what part can Medicare patients pay on a cash basis? And the government is very strict about that. They have Medicare fees, and it's a different fee for participating versus non-participating. It's 5% less. The allowable amount is 5% less for non-participating physicians. But the non-participating physicians can charge in excess of the allowable amount, but only up to a certain point, called the limiting charge. So there's a federal limiting charge law which restricts, and it's fairly restrictive, as far as how far above the allowable amount, the Medicare allowable amount, a physician may legally charge. And you'll also note that some states also have a state limiting charge law which further limits how much you can charge. Now, I'm in New York State. So in New York State, non-par physicians have a federal and a state limiting charge law that restricts how much non-participating physicians can charge. And as it works out, it's a little bit less than the fee for participating physicians. Participating physicians, of course, cannot charge anything above the Medicare allowed amount because that is illegal. As far as treating Medicare patients who are on Medicare, I mean, when a Medicare patient sees an opted out physician such as myself, I've been opted out since 2004. Most of my practice are Medicare patients. You can charge whatever fee is agreeable between the patient and physician. So Medicare does not set fees or price fix fees in the opted out practices.
Okay. We have time for one last question now.
Hans Watson from Ohio. So once again, I'm going to bring the younger crowd view in and explain it. When I head back to finish residency, I currently have about 5 people that already said, bring me word of what's going on. They're all looking at the website, etc. So my question to you is going to be a lot different, and it's probably going to be to the AAPS board here, is what you're explaining is well known among the young residents and newly graduated residents. But what's not clear is, in 2 sentences, how do I say, this is our fix to it? Here it is, and here's how you get behind it. And this is so important. We look at, this is what George Washington was able to do. This is how Hitler was able to take Germany in a totally different direction. He gave them hope of something. Now, I obviously know he didn't stand behind what he claimed. This is how many great influential leaders through military history have been able to accomplish things. And we have an opportunity. They've provided us with such a problem that if we just come in and say, look, we recognize it's a problem, but there's hope if you support us and do what we say. These 2 lines are how we're going to do it. And currently, we have 2 pages that explain that. What as the AAPS is our message of, if we do this and here's how you help that to happen, we fix this. And so my question is, what is our stick? What is our big push? Thank you.
Clearly, this is a start. It's called education. You've got to put the facts out there, because I will tell you there's a lot of myths about the way the Medicare program works and what it covers. So this is the first step, education. Also, opting out of Medicare as a physician gives patients more choices. Medicare rations care based on the fee schedule. That's how they do it. Medicare has lowered some fees to 0. Well, guess what? When they lower the fee for that service to 0, how many physicians provide that? Nearly 0. So Medicare rations care based on the fee schedule. Opting out of Medicare as a physician helps patients, gives them more choices at an affordable cost, better access, and I think higher quality care, because physicians who are opted out don't push people through like cattle. If you're in the Medicare program, you better herd those patients through like cattle if you want to make a living. Patients, turns out, don't like that. Number 3, in terms of legislative solutions, their government has made a lot of people dependent on Medicare. We can't just pull the rug out from under them. Everybody understands that. But there has to be some sort of a phase out to more of a private system where people have skin in the game. Unless you have people with skin in the game, there's no cost containment. That is the best cost containment. If care has to be rationed, it should be done by patients and their families, as they do for food and everything else. So that's basically an outline of the solution. Thank you.